Hello everyone, and welcome to today's live broadcast, testing for prostate-specific antigen, PSA, to screen or not to screen, presented by Shahram Shahangian, PhD, Senior Health Scientist, Laboratory Research and Evaluation Branch, Division of Laboratory Systems, Center for Surveillance, Epidemiology, and Laboratory Services, Office of Public Health Scientific Services, Centers for Disease Control and Prevention. I am Christina Mahalik of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your question into the box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located on the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window or use the Q&A button to let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the button in the bottom left corner and follow the process to obtain your credits. Please join me in welcoming Dr. Shahangian. I will now turn the presentation over to him. The floor is all yours.
My presentation will focus on issues relating to the effectiveness of cancer screening and prostate cancer screening. And I would begin by providing the criteria for effectiveness of any health screening that has been adopted by the World Health Organization. I will follow this presentation by presenting the major biases that impact a perception of screening effectiveness, and most of these biases are favorable in terms of adopting screening. Then I will continue with providing the recommendations by major U.S. health organizations on the use of a PSA test to screen for prostate cancer, and then examine PSA screening to screen for prostate cancer in terms of how this test meets each of the WHO's effectiveness criteria, and finally conclude with several key messages that relates to consequences of cancer screening in general and prostate cancer screening in specifically using the PSA test. The learning objectives of my presentation are to audience to be able to describe the WHO's criteria for effectiveness screening and use PSA as a testing model to evaluate how this particular test meets each of those screening criteria. Also describe major screening biases, the major groups that are targeted by cancer screening and any screening for that matter, and the consequences of cancer screening and PSA screening, and finally describe the current perspectives on the recommendations and guidelines relating to PSA screening for prostate cancer. The WHO's criteria that were first proposed by Junger and Wilson back in 1968 that remains to be still adopted by the WHO can be framed into 7 broad categories. The first category has to do with a disease having significant societal burden of disease in terms of health burden and socioeconomic burden. The second criterion has to do with the clinical performance of the test used in screening, negative and positive predictive values, how predictive a negative result is to indicate absence of disease, and how predictive a positive test result is to indicate a disease. The target population should find the screening test to be acceptable to them, and the screening program should be feasible. This is the third criteria. The fourth criteria has to do with acceptable cost effectiveness, and that has to do with life years saved or quality adjusted life years saved. And usually the cutoff line is $100,000 for life years saved, and increasing the quality adjusted life years saved is used as a measure in terms of cost utility analysis. The screening program should effectively intervene before onset of disease. There should be a good asymptomatic phase so that the disease could be intervened, stopped, or the progression of the disease could be slowed down. Certainly in cases of screening that there is not a significant net benefit to the patient, there should be informed consent on the part of the patient, and certainly patient confidentiality, if warranted, should be adopted. And finally, where the rubber meets the road, there should be a better population health outcome with screening when compared with absence of screening. I've listed here on this slide the major screening biases. Lead time bias has to do with finding the disease earlier, but not necessarily impacting the outcome. Here the window would be shifted to the left without necessarily impacting the time of death. The length bias has to do with the fact that the screening tends to detect more slowly progressing diseases. So in the screening trials, when screening is compared with no screening, individuals who have submitted to screening seem to have a better health outcome, and that is because of the length bias, because the screening tends to detect slowly progressing cancers and miss aggressive cancers. Then there is an issue of presenting the risks to the patient in terms of relative vis-a-vis absolute risk. A presentation to the patient, for example, that the risk of the disease dying from cancer is decreased by say 20 to 30% looks quite impressive versus the same information given in absolute risk of reducing the chance from dying from cancer by 1 in 1,000 in a 10 to 15 year time period. The first presentation seems to favor screening, while the second presentation of absolute risk, which is more objective, does not make screening so attractive. And then this is very important, disease-specific. In the case of cancer, cancer-specific mortality is used as a primary outcome measure versus all-cause mortality. And that's extremely important because many cancers, individuals die from diseases other than cancers that results from interventions, from diagnostic maneuvers, treatment modalities that are not captured in cancer-specific mortality. And the gold standard of any screening trial is all-cause mortality. But the issue with all-cause mortality is that we need more than 1 million patients in randomized controlled clinical trials in order to show a significant change. And that is why virtually all screening trials use cancer-specific mortality as a primary outcome measure. This slide shows the recommendations by the major health organizations that can be grouped into two broad categories. The first group, led by the U.S. Preventive Services Task Force and also College of Preventive Medicine and Academy of Family Physicians, they advocate not using PSA screening of men at any age. Currently, the U.S. Preventive Services Task Force is revising or updating the recommendations. They released a draft in April of this year, and perhaps later in the year, the final recommendation would come up. But the current recommendation currently on the part of the U.S. Preventive Services Task Force, a recommendation that the CDC follows, is not to recommend screening of men at any age. The other set of recommendations are targeted for only a certain age group of men, and that is to offer screening to men beginning at the age 50 to 55 up to 69, but only when there is an informed shared decision making, and only when the men agree to be screened, and not screen men with expected life expectancy of less than 10 years. And this recommendation is currently by the American Cancer Society, Urological Association, College of Medicine. And the rationale for this is that this second recommendation is that there is some strong likelihood of reducing cancer-specific mortality because of screening, and so men should have the option to be screened or not to be screened. The previous group recommend against the screening because there is a likelihood that the net benefit of screening is negative, namely considering the complications that can result from screening and subsequent treatment, the quality adjusted life years seem to be less with screening compared to no screening. Now, this next set of slides, I would like to discuss the PSA screening for prostate cancer against each of the 7 WHO criteria. The first criteria, if you recall, was having significant societal burden of suffering in terms of health and socioeconomic variables. According to the NCI's latest estimate for this year, there would be about 161,000 new diagnoses of prostate cancer made. During the year, however, about 27,000 men will die from their prostate cancer as opposed to other causes. The prostate cancer for men constitutes 11% of all diagnosed cancers, which is significant, but it leads to only 4% of all cancer deaths. So certainly the societal burden of the disease is large, but we should note that less than 1 in 6 men diagnosed with prostate cancer actually die from their cancer rather than from other causes. 5 out of 6 die eventually from other causes and not from their cancer. The second criterion has to do with clinical performance of the PSA test. And I've listed here on this slide the positive predictive value, negative predictive value, as well as clinical sensitivity and specificity. The positive predictive value of this test, when it started to be used back in the early 1990s as a screening test, the studies showed that the majority of men that have a positive findings, namely PSA of more than or equal to 4.0 microgram per liter, 1 out of 4 of them only had prostate cancer as evaluated by a biopsy, and the remaining men that had positive PSA values exceeding this level were due to non-malignant conditions, mostly benign prostatic hyperplasia, and also due to inflammation and infection of the prostate gland. In a study that was conducted over a 7-year period, subjecting a group of men to regular PSA screening as well as digital rectal examination, and none of them showed any evidence of disease. When all of these men were subjected to prostate biopsy, about 15% of them showed were positive for cancer. This shows that the negative predictive value of this test is 85%. Namely, out of the people that are supposed are negative in their screening, 15% actually do have cancer. In an elegant study that Thompson and colleagues did back in 2004 and was published in JAMA, listed here, when a group of men, all of them were biopsied and their PSA measured, serum PSA was measured, only 20% of them that were positive in biopsy had PSA value exceeding 4.0 microgram per liter. So this shows that there is a great number of individuals that have the disease, and PSA test actually does not detect them. And when we use the relationship between clinical specificity and positive predictive value, prevalence of 1.8% for all adjusted all races, and clinical sensitivity as noted at the bottom of the slide, we get a figure of 75% for clinical specificity, meaning that individuals that don't have a disease, a quarter of them actually come up with positive PSA findings. So based on this slide alone, the clinical performance of the PSA test to diagnose prostate cancer is not all that impressive. Is PSA screening for prostate cancer acceptable and feasible to implement? Based on evidence of common use being PSA being the most widely lab-based screening test in men, and given the fact that about 30% of men between the age of 50 and 64 annually get screened, and 10 to 15% of men above 65 about 65 and older get screened based on the studies that are noted here. It appears that the test is acceptable to the US population, and certainly it is feasible to implement. In terms of cost effectiveness, however, really the findings are mixed. Most authoritative study that was conducted that looked at various screening strategies found testing once every 4 years of a group of men between 50 and 69 to be cost effective at about $92,000 per life year saved when you use the cutoff value of 100,000 per life year saved as the criteria below which to be cost effective. And in many other scenarios, it exceeded this threshold. And all of the studies that have been conducted under a wide range of assumptions for quality, for utility to determine quality adjusted life years show actually a decrease in quality adjusted life years. Well, the PSA test is not very good in predicting aggressiveness in the sense that a little over half of all cancers are overdiagnosed and also overtreated. And any approach that would find more cancers without quantifying the clinical significance by virtue of not having a good prognostic markers tend to increase overdiagnosis and overtreatment, which is a harm to men being screened. Is informed consent commonly practiced? In one study, about half of physicians surveyed did not routinely discuss PSA screening with men while ordering the test. In a CDC study of 2013 behavior risk factor surveillance systems, men from 3 states, Delaware, Hawaii, and another state that I don't recall now, I need to go to my notes. They were found not to be engaged in screening. The vast majority of them, 64% of them, did not engage in any shared decision making. So the evidence does not support effectiveness of informed and shared decision making to improve appropriate use of PSA screening for cancer, in the sense that discussions of disadvantages or advantages and disadvantages tended even to increase uptake of screening, and discussions of uncertainties surrounding screening did not impact PSA utilization rate. So it appears that provision of information is not impacting the screening rate, and at times increases it. So, but given that all health care organizations, including the CDC, advocate informed and shared decision making, there is numerous barriers that have been reported in the literature to dissuade informed decision making that relates to discomfort, discussing life expectancy, lack of time of the busy clinicians, discomfort with discussing the uncertainty for effectiveness of PSA screening. There is limited awareness of PSA screening guidelines by many physicians, and certainly patients' expectations come into play to have increase PSA screening when it is not warranted, and certainly fear of malpractice litigations that has been documented in the literature as being advocating screening, even though evidence-based guidelines do not support screening of, say, older men, a certain age population, for sure. The impact of decision support systems on the provision of them to the patient has a mixed result. Some studies have shown no impact on PSA screening, while some studies show that provision of decision support tools to the patient may actually decrease utilization rate. This is both on the part of the clinical decision support system, as well as support interventions provided to the patient. So on both ways there are mixed findings, but the clinical decision support system, if it is a specific, a study has documented that screening of older men 75 years and above may be decreased, and the decrease will be sustained over time. But the issue with the support interventions for men is less clear in the sense that some of these interventions seem to have the opposite impact to increase screening rate. And finally, better population health outcome, which is the last criterion that is used by major health organizations in terms of evaluating screening effectiveness, based on a meta-analysis of 5 randomized controlled trials, including the European and US trials, there was no reduction in cancer-specific mortality rate. The largest trial conducted in Europe in 8 countries, however, showed a significant reduction in cancer-specific mortality rate in the screening arm compared to control arm. And both the US trials and European trials have been criticized, with the US trial having a high contamination rate. In the control arm, there is a screening, PSA screening, once every 2.5 years. Ideally, you don't want to have any screening in the control arm, but unfortunately, because of the popularity of PSA screening, it is still in the control trials, it is being adopted. The European trial has been criticized because of non-uniform implementation and differences in the screening sites and different study protocols that were implemented. But having said all these, none of these screening trials alone or in combination showed any statistically significant impact on the all-important all-cause mortality, which is really the gold standard of any screening test. There are certainly many adverse impacts of PSA screening, and we know that most men with PSA screening, 70 to 80% of them undergo invasive treatments, surgery or radiation therapy, and these treatments are not harmless. Up to 5 in 1,000 men die within 1 month of prostatectomy, removal of prostate glands, and 1% to 7% will have serious complications, but they will survive. Prostatectomy and radiation therapy gives rise to a myriad of conditions: erectile dysfunction, urinary incontinence, and bowel dysfunction in at least a quarter of men. And these are major complications that certainly impact quality of life. So there are really 5 major groups of individuals that are targeted by cancer screening. Patients with no cancer, where morbidity and mortality actually may become significant if the diagnostic maneuvers and that would go into pursuing the rule in or rule out would cause to significant morbidities. Patients with only adverse events resulting from diagnosis and treatment that would not be consequential if they had not screened, and certainly in this group of patients, the second group, there would be a reduction in quality adjusted life years. Patients successfully treated regardless of screening. So in this group of patients, we don't see any impact of screening, because when the person came up with the clinical signs and symptoms, the disease was treatable, and the screening would not have made any difference. Patients with incurable cancer at time of screening, and these are a significant minority of cancers, are so rapidly progressing that at one stage, at 1 year, you can have no disease. At the subsequent year, you can have disease that has already spread and is already too late. Certainly, screening does not help these men or these persons, for that matter, in the broader context of cancer screening. But there may be some impact on the individual's and his or her family's decision-making once they find that there is an aggressive tumor for decision-making at the end of life. And finally, and this is the group that really cancer screening is designed to help, are individuals who are have incurable disease at the time they are diagnosed, but they are curable if they are identified by screening. And we really, with many cancers and many diseases, we don't know how large this group of patients are. In the case of cancer screening and laboratory screening for cancer, the two disease conditions that show that the cancer has a strong net benefit is cervical cancer and colorectal cancer, but that is only for certain age groups, and all the other cancers are not supported by evidence. So the major consequences of cancer screening has to do with prevention of morbidity and mortality from the disease itself. But at many times, morbidity and mortality are not significantly impacted. There can certainly be testing cascades and uncertainties about the disease presence that can result in significant morbidity and some mortality downstream. There are certainly many cases, and this comes to mind particularly with respect to prostate and breast cancer, diagnosis of cancer in situ that can prove to be inconsequential and could have very well been left alone, but the treatment that goes into addressing that may have significant consequences, particularly in the case of prostate cancer, between these two cancers. And certainly, as I noted with respect to prostate cancer, diagnostic evaluation and treatment can result into myriad of complications, infection of the prostate gland, erectile dysfunction, bowel dysfunction, and urinary incontinence, and others. So on one hand, better ways are needed to screen by using effective prognostic markers to reduce over-treatment for prostate cancer. And regretfully, we don't still have very good prognostic markers to decide which cancers to treat and which ones to leave alone. But on the other hand, if we don't screen men with that have consequential cancers, that may result in lack of treatment where the cancer could be prevented. So this calls for screening certain cancers and acting accordingly to treat them. In the later years, there has been increasing active surveillance in the sense that individuals that come positive, they would be monitored more frequently with PSA test and digital rectal exam, and and many men decide to be monitored for some time. But the fact of the matter is most men finally succumb to wanting to have the peace of mind and having the prostate glands removed with its consequent morbidities, as I mentioned before. So ultimately, the question may really become not necessarily whether to screen certain men for prostate cancer, rather how best to screen if the men want to be screened, how to best screen and only treat men for their cancers when it is necessary to do so. Willard Whitmore, a very well-known urologic oncologist at the Sloan Kettering Memorial Institute in the 1990s, when he, like, by the way, he died from his prostate cancer, he framed two very important questions. If cure is possible, is it necessary? And when cure is necessary, is it possible? Do we need to treat all cancers? And are there effective means to treat them? Do we have effective and validated prognostic markers to only treat cancers that are likely to be consequential if left alone? Can we identify men with aggressive localized cancers early enough to intervene effectively? And if not, can metastatic disease be effectively treated? We can, but only sometimes, identify men with aggressive localized cancer early enough to intervene effectively. And most metastatic cancers have poor survival rates despite treatment. And we still lack effective and validated prognostic markers in order to treat only cancers that are likely to be consequential if left alone. Primum non nocere. We must adhere to the Hippocratic oath ingrained in allopathic medicine, and to first do no harm. Please contact me if you have any further questions. The comments that I have made, I should say, are those of mine and do not necessarily reflect the official position of the Centers for Disease Control and Prevention. Thank you.
Thank you, Dr. Shahangian, for that informative presentation. We will now start with the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of the presentation window, type your question into the box that appears on the screen, and click on the send button. We'll answer as many questions as we have time for. Let's get started with our first question of the day. Let me hop in here. Okay, our first question of the day asks, how is the screening criteria adopted by the World Health Organization different from those used for development of screening recommendations and guidelines in the United States?
Well, can you hear me? basically the major difference is that the WHO has a criterion that relates to cost effectiveness or cost utility that is increasingly being used. There are a number of other criteria that really goes into the very last criteria that deals with better population health outcome. But the major U.S. health organizations, although some examine cost effectiveness, their recommendations is not based on cost effectiveness and cost utility. Rather, it is based on clinical effectiveness.
Excellent. Thank you for your answer. Our next question asks, how do the recommendations by various health organizations for PSA screening for prostate cancer differ or agree with each other, and what should men do?
Care organizations agree, all health organizations agree that prostate cancer screening should not be done routinely using the PSA test for men younger than 50 and older than 69. Where the difference comes is with one group led by the U.S. Preventive Services Task Force, which currently recommends that screening should not be done routinely for any men regardless of age. However, the other group led by the American Cancer Society and Urological Association maintains that there should be an opportunity given to men between the ages of 50 and 69, whether they want to undergo screening, but only after providing them with an opportunity for informed and shared decision making. And this group does not recommend screening any men with life expectancy that is less than 10 years.
Thank you. The next question asks, what are some risk factors for prostate cancer, and is there convincing evidence for effectiveness of prostate cancer screening in men at high risk, such as African Americans and those with family history of prostate cancer?
Well, actually, the most important risk factor for having prostate cancer is age. But I should say that there is currently no convincing evidence that age, race, or family history is relevant in terms of effectiveness of PSA screening for prostate cancer. Older individuals do have a greater probability of prostate cancer, but there is a greater probability of them dying from other comorbidities and complications, and prostate cancer being typically slowly progressing would not be of material issue in that respect. In the case of African American men that has a higher prevalence of prostate cancer, there is also no evidence that increasing at an earlier age or screening more frequently would result in better health outcome. The evidence is not there. The individuals that have a positive family history, a lot of them end up being diagnosed with more prostate cancer because they undergo more screening. And as a result, they are increasingly diagnosed and labeled with prostate cancer. But again, there is no evidence that increased screening or earlier screening of this subgroup of individuals would result in better health outcome.
Thank you. And based on time constraints, looks like this will be the last question of the day. And this asks, why should the preferred outcome measure to assess the effectiveness of cancer screening be all-cause mortality and quality-adjusted life years instead of, respectively, cancer-specific mortality and life years?
As I noted previously, the gold standard of any screening trial is all-cause mortality because it can capture death from causes, say, resulting from diagnostic maneuvers and treatment modalities that could be related to the treatment of cancer. So when a cancer-specific mortality rate is evaluated, there could be a decrease in cancer-specific mortality, while in point of fact, there may be an increase in all-cause mortality because many of those treatments may result into mortality that is not captured by evaluating cancer-specific mortality. The very fact that all the screening trials use cancer-specific mortality results from the fact that in order to see differences in all-cause mortality, you need very large number of participants exceeding 1 million in order to show statistical difference. And that is why the vast majority of these trials, even though they assess all-cause mortality, do not show any significant change in all-cause mortality. But it remains to be the gold standard because of the fact, as I noted earlier, that there are mortalities resulting from the treatment of the disease itself that is not captured by cancer-specific mortality rates.
I would like to once again thank Dr. Shahangian for his presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February of 2018. You will receive an email from LabRoots letting you know when the webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us, and we hope to see you again here soon at LabRoots. Goodbye.